Next, let me invite Dr. Rehna Rasheed, Assistant Professor and Retina Consultant at Amrita, to present her talk on optic neuritis, what is new, maybe starting off from where NSD Raju sir left.
Good afternoon again. So topic is optic neuritis, what has changed? We all know that the largest collaborative study which was done on optic neuritis was the optic neuritis treatment trial, which was done in 1980s, which looked into acute cases of optic neuritis. And they found that regarding the treatment, IV methylprednisolone could hasten the recovery of vision, but the thing is, the final visual outcome is the same. But we should remember that it was done in Caucasian population with typical optic neuritis. So regarding India, once it was thought that demyelinating diseases were rare. However, most of the studies now has proved it otherwise. A more recent population-based survey in urban Bangalore has even showed 50% of the patients with optic neuritis converted to MS during long-term follow-up, and neuromyelitis optica spectral disorder constitute nearly 20%. This change in epidemiology is due to greater awareness about the disease, better documentation, and due to low threshold for MRI among neurologists and us. So how is optic neuritis in India different from the West? We have more of atypical presentation which have a poor visual prognosis if not treated, and more of NMOSD and other atypical optic neuritis than the West. So optic neuritis can be divided into typical and atypical. The typical one is the one which is associated with MS or clinical isolated syndrome, which presents with unilateral, subacute, painless loss of vision seen in young females in the age group of 20 to 30 with pain on eye movements, and usually they have mild to moderate vision loss, and they usually present with retrobulbar neuritis. So let's go to this case, which is a 31-year-old lady who presented with decreased vision and pain on eye movement of the right eye for 3 days. Visual acuity in the right eye was 36 with an RAPD and a defective color vision, and the left eye was 6.6. The disc is normal, so it is a case of right eye retrobulbar neuritis. The field showed a centrocecal scotoma, and MRI of the brain and the orbit with contrast was done. All cases of clinical isolated syndrome should have an MRI of the brain and the orbit with contrast. First, to know that there is an explanatory lesion to explain the decreased vision, and to know if there are any other demyelinating lesions in the brain or the spinal cord, to diagnose or risk assess MS and diagnose NMO. So this patient had an enhancing lesion in the optic nerve here. So the MRI of the brain showed enhancing hyperintense lesions in the periventricular area, which is suggestive of multiple sclerosis. So this is a case of typical optic neuritis, which is associated with multiple sclerosis, which require IV methylprednisolone followed by oral steroids and referral to the neurologist. They do CSF examination looking for oligoclonal bands, and the presence of these bands in the CSF, which is not present in the concomitant serum, would help to refine the risk conversion to MS. And they also start these patients on disease-modifying therapies. So now we go to the second case, which is a 49-year-old lady who presented with decreased vision of 2-day duration in the left eye. Visual acuity in the right eye was 6.6. Left eye, there was an RAPD, and the vision was hand movements. And unlike the first case, there is a disc edema. So OCT RNFL, it confirmed the presence of peripapillary nerve swelling in the left eye. And when doing the MRI, you can see that there is enhancement in the optic nerve here. That is an anterior section. And even when you go posteriorly, it is there, reaching up to the chiasm. That is a long segment of the optic nerve is involved, which is specific, or it's very much for NMOSD. And also in the spinal cord also, larger segment of the spinal cord is involved, at least 3 segments of the vertebrae, which is very specific for NMOSD. So these patients require neurology referral, and this is a case of diagnosis of optic neuritis in the left eye with neuromyelitis optica. So what is neuromyelitis optica spectral disorder? It is a demyelinating disease with antibodies against aquaporin water channel on the astrocytes. It's more common in Asian and African population and more common in females itself, but it's a 30 to 40. It's marginally more than the MS age group. And vision loss at presentation itself is profound and rapid, and if you don't treat, the visual prognosis is poor. And there is a consensus criteria for NMO in which there is core clinical characteristics and antibodies. And one of the core clinical characteristics is optic neuritis. If there are 2 core clinical characteristics, NMO can be diagnosed, or one with an antibody positivity. So these patients require urgent treatment with IV amethylprednisolone. If you don't treat, the outcome is going to be different, not like MS. And also they require long-term immunosuppressants. Our patient improved, but in certain patients there may not be improvement or there may be decrease in vision and they require either plasma exchange or IVIG for MOG. So when you use tests for NMO or when do you say that the patient have atypical optic neuritis or MOG? MOG, as anesthesia said, it's myelin oligodendrocyte glycoprotein optic neuritis. So if the age is outside 20 to 45 years, if there is bilateral optic neuritis, painless to severe vision loss, vision not improving or worsening on systemic steroids, or occurs once steroids are tapered, or if there is severe diswelling, or consider for any optic neuritis unless classic. So atypical optic neuritis could be either inflammatory or infectious. The inflammatory causes crayon. Crayon is chronic relapsing in optic neuritis. It's a condition where the patient responds nicely to steroids. There is no underlying cause, but steroid dependent. Once steroids are stopped or tapered, it can relapse. So they require long-term immunosuppression. Other causes, SLE, vaginous, autoimmune optic neuropathy, NMO, MOG, and infection should also be ruled out. So I would like to say what is the difference between this multiple sclerosis, NMO, and MOG presentation. MS, we all know it occurs in young adult female, but NMO, it can occur in a bit more aged females, and MOG can occur in any age. And multiple sclerosis, it is more in Caucasians, but NMO is more in Asians and Africans. MOG can occur in any race. So multiple sclerosis, it's mild to moderate vision loss, which occurs in optic neuritis, but both NMO and MOG, it is severe vision loss. But there is good recovery in multiple sclerosis and MOG, poor recovery in aquaporin. In MOG, even with one dose of IVMP, the vision can improve to 6.6. And the disc edema, we all know MS is retrobulbar neuritis, but MOG and NMO, they can present with disc edema. MOG, typically, it can present with bilateral disc edema. And regarding the MRI, MS usually have a short enhancement of optic neuritis, but in NMO, they can have long enhancement, and in MOG positivity, there can be perineural enhancement. So to summarize, a stepwise approach is required for diagnosis and management of acute episode of optic neuritis. Any typical optic neuritis should be thoroughly investigated since timely diagnosis, prompt treatment is key to prevent and improve prognosis. Contrast enhancing MRI of the brain, orbit, and spine are indicated for diagnosing various causes of optic neuritis and to fulfill the diagnostic criteria for MS and NMO and prognosticate the disease outcome. It should be noted that NMO-ST-related optic neuritis may actually worsen with the interferons, and differentiation should be made before the initiation of the treatment. And a long-term management protocol is needed to prevent further attacks and decrease the disease burden. Thank you.